I've titled this talk, Maturation of a Transformational Technology. The reason being, we've spent the last decade doing a series of clinical trials in which we've been able to show the efficacy and safety of this technology that allows us to now replace the primary valve that connects the heart to the rest of the body in a purely percutaneous manner. This had previously been entirely the realm of surgery, but now is something that we can do in a much less invasive manner. I have a few disclosures to reveal there, and I do have to indicate that I have been part of the partner trials in an unpaid manner as part of the case review board. So in terms of this landscape of TAVR, there are really 6 large clinical trials that have been performed over the course of the last decade. 3 in the setting of the balloon expandable device, the Edwards SAPIEN device, and then 3 analogous trials in the setting of the self-expanding Medtronic core valve. And basically what we've done is walk down the surgical risk continuum. The original trials back in the late 2000s looked at patients who were either ineligible for surgery or at high risk for morbidity and mortality at open heart surgery. Typically, these were patients with STS scores of 8 or above. That was the original partner trial and the original core valve pivotal trial. Once those trials wrapped up in the early 2010s, the next phase was to move into intermediate surgical risk patients. And that's where the Partner 2 trial and the SIR-TAVI trial came up. And again, these were patients with STS scores in the intermediate range, typically between 3 or 4 and about 8. Again, we saw fantastic outcomes for TAVR in this intermediate risk cohort. And then the last phase was to move into the low risk cohort, those with STS scores below 3 or 4. And that was the Partner 3 trial and the core valve Evolute low risk trial, both of which were just announced at ACC this past spring. And we'll talk about those results as well. So essentially, as I mentioned, we've walked down the surgical risk continuum over the last decade and seen that TAVR is in fact a very viable alternative to surgery in all of these surgical risk categories. At the same time as we walked down the surgical risk continuum, we also saw a rapid progression in the technology within the TAVR devices themselves. We've seen 3 generations of both the balloon expandable and the self-expanding platform. From the balloon expandable side, we went from the SAPIEN to the SAPIEN XT and finally to the SAPIEN 3 valve, which is now the workhorse of the balloon expandable platform. And similarly, in the self-expanding platform, we went from the original core valve or core valve classic to the Evolute R, and now to their workhorse, the Evolute Pro. And you'll see how the trial data and the evolution, the iteration of the technology both interact with one another to potentially, and not just potentially, actually produce better outcomes for patients over time. So let's begin with the original trial in this field, and that was the original partner trial. This enrolled in the United States between about 2007 and about 2010. And there were 2 cohorts in this trial. Cohort B consisted of the inoperable patients. These were patients typically with STS scores above 15 that were deemed by a surgeon not to be a surgical candidate. And the reason they started with this population was primarily because this was truly the unmet need. There were studies from the pre-TAVR era looking at how many patients with severe aortic stenosis were even offered surgical AVR. And the estimates were that up to 40 to 50% of the patients with this condition were not even offered surgery because they were deemed ineligible for surgery based on their age, comorbidities, other factors that made them poor surgical candidates. So there was the huge unmet need. So with cohort B, what we did was we randomized those patients to either TAVR, transfemoral TAVR, or medical therapy. And what were the results of that? Here are the Kaplan-Meier curves. Replacing the valve as compared to nothing portended a substantial mortality benefit. And you can see that mortality benefit from 12 months to 24 months actually grew from 20 to 25%. Basically, medical therapy for this condition is hospice. You have to replace the valve if you are going to see a mortality benefit for these patients. So that one was a slam dunk. Next up, cohort A. These were the patients that, while still surgical candidates, they were high surgical risk. Okay? Typically STS scores, as I said, between 8 and 15. These patients were randomized 1-to-1 between TAVR, both from a transfemoral or an alternative access approach, which oftentimes was transapical at that time, versus surgical aortic valve replacement. And this was powered as a non-inferiority trial. And here you can see the Kaplan-Meier curves, and they hug one another effectively, proving that TAVR in a high surgical risk population is non-inferior to surgical AVR. Based on these results, in 2012, the FDA offered approval for TAVR in patients who are either inoperable or at high surgical risk. Now, at the same time, or a little bit after that actually, the self-expanding platform was coming into its own in terms of clinical trials. And the key trial there was the CoreValve US pivotal trial. And their trial was organized very similarly to the original partner trial. They called the inoperable cohort, or cohort B here, the extreme risk cohort, and those patients were randomized to, actually they weren't randomized, they were just a registry given transfemoral TAVR. And the other cohort, the high risk cohort, were randomized 1-to-1 between TAVR and surgical AVR. And as I said, this was not truly randomized in the inoperable cohort because at this time the original partner trial had already been published and it was deemed unethical to randomize patients to medical therapy given the fact that we knew TAVR was effective in saving lives. As a result, that extreme risk cohort was measured against a statistical performance goal. And you can see the Kaplan-Meier curve here for that. TAVR, using the self-expanding platform, more than met the expected statistical targets, proving that TAVR with a self-expanding platform in inoperable patients saved lives. Moving now into the intermediate risk realm. Based on those two trials, partner and the CoreValve US pivotal trial, we now knew that the high-risk inoperable patients benefited from TAVR. The next step was to move into the intermediate risk population, and this is where the Partner 2 trial begins. This was a randomized controlled trial looking at patients at intermediate surgical risk, STS scores typically between 4 and 8. These patients were randomized 1-to-1, TAVR versus surgical AVR, and that was TF TAVR or alternative access TAVR, depending on the availability of femoral access for these patients. The valve used for this study was the second generation balloon expandable prosthesis, not the original SAPIEN valve. So as I mentioned, the technology continues to progress in terms of the valve and the delivery systems as we are gathering this evidence about the safety and efficacy of TAVR. So using the second generation SAPIEN XT valve, we then looked at the primary endpoint of all-cause mortality or disabling stroke at 2 years. And this is really where my introduction to TAVR came. I was a fellow back in 2011, just as we were beginning the Partner 2 trial here in Houston, and it was my opportunity to learn this from the ground up. And here's the Kaplan-Meier curves for the Partner 2 trial. looking at the entire cohort, both the transfemoral arm and the alternative access arm, powered for non-inferiority for the primary endpoint of all-cause mortality or disabling stroke, you can see the curves are relatively identical. There seems to be a slight tendency in favor of TAVR, but not statistically significant when you look at the overall population, including transfemoral and alternative access. However, when you look at just the transfemoral patients, those who did have access to have a purely percutaneous transfemoral TAVR, not requiring any form of surgical cut down, now all of a sudden those Kaplan-Meier curves diverge significantly from one another. This was not powered as a superiority trial, so we cannot claim superiority based on this, but those two curves are statistically significantly different from one another. So the takeaway from this was TAVR using SAPIEN XT and surgery are similar, i.e. TAVR is non-inferior to surgery for the primary endpoint of all-cause mortality or disabling stroke at 2 years. There was this trend towards superiority in the transfemoral cohort. So the next step was to think about what happens when we bring in an even better valve, the third generation valve, the SAPIEN 3. The technology was actually moving faster than the rate of the trials. So as Partner 2 with SAPIEN XT was enrolling, we already had the third generation SAPIEN 3 valve, which had a significant number of advantages to it. Primarily, you see there that PTFE skirt at the bottom of the valve. That skirt minimized the amount of paravalvular regurgitation. In the first two generations of the valve, one of the significant Achilles heels of TAVR, particularly as compared to surgical AVR, was paravalvular leak. Unlike surgery, we're not cutting out the old valve. We don't have a sewing ring that's completely adherent to the aorta. It's merely a stent. And as a result, we saw fairly significant rates of paravalvular regurgitation in the first two generations of the valve. And there were studies indicating that moderate or more paravalvular regurgitation did in fact affect mortality for these patients. So it was critical to minimize that paravalvular regurgitation. And that's really the advantage that that SAPIEN 3 valve provided. Beyond that, it was also a valve that was significantly easier to deliver, lower caliber delivery system, 14 French as compared to the original 24 French SAPIEN systems.
Lord, that's huge.
Exactly. The delivery systems for all these valves got smaller and smaller and smaller over time, which meant less invasiveness, less chance for mortality and morbidity for the patients. So as I said, the technology got better and better. So rather than randomizing these patients, the decision that the FDA made based on the quality of the data from the previous trials was to merely compare a non-randomized registry of patients with SAPIEN 3 against the surgical arm of Partner 2A. It was a propensity-matched analysis whereby both a high-risk cohort receiving SAPIEN 3 and an intermediate-risk cohort receiving SAPIEN 3 were then compared to that surgical cohort from Partner 2A. In terms of the characteristics, in the SAPIEN 3 high-risk group, the average STS score was 8.6%, the average age just about 83 years, and most of these patients were treated from a transfemoral route. As we mentioned, the delivery systems were getting smaller and smaller, and as a result, the bulk of these patients could be treated purely percutaneously via the transfemoral route. By far the best form of TAVR, what the data has shown us, is this minimally invasive, non-surgical, transfemoral TAVR. Similarly, looking at the intermediate risk group, again, the majority were treated transfemorally, here even higher, 89%. The average STS score in this cohort was 5.3%, average age about 82 years. So still a relatively older cohort. And here's the data from that. When you look at both the intermediate risk and the high risk SAPIEN 3 cohorts, the morbidity and mortality is all in the neighborhood of 1%. Fantastic numbers. No other trial up to this point had showed mortality rates at 30 days this low. Okay? Even when you looked at the alternative access cohort, in the high-risk patients, morbidity and mortality was a little bit higher. But look at the far right there, the intermediate risk S3 cohort. Even with alternative access, we're looking at mortality rates less than 2%. Fantastic results. This was a huge leap forward. That third generation was a huge leap forward, an exponential leap forward as compared to the first two generations.
I mean, that's far superior to surgical.
And that's exactly what
numbers.
the data is going to show us. Exactly. So in terms of this comparison to the surgical cohort, it was retrospective, obviously, because we have this registry of S3 patients that we're going to retrospectively compare to the surgical arm of Partner 2A. They were propensity matched, so that it was an even match. And the three endpoints that we were looking at were all-cause mortality, disabling stroke, and aortic regurgitation, moderate or greater. The goal, as we said, was to evaluate at 1 year for these endpoints with this pre-specified propensity score analysis. It was all-cause mortality, stroke, or moderate AR at 1 year. And here's the results. First off, looking at it from a non-inferiority standpoint, in order to meet the non-inferiority criterion, TAVR would have to fall somewhere to the left of that blue line. The red square there at the left is where TAVR actually fell, so easily met the non-inferiority criterion. Looking at it from a superiority standpoint, anywhere to the left of 0 favors TAVR. And you can see, just as Joe points out, these are numbers that are well ahead of anything that has ever been published in the surgical literature. Looking at which of these endpoints drove that superiority for TAVR, it was a mortality advantage. So this was not anything soft. It was a true mortality advantage in favor of TAVR for intermediate risk patients. There were fewer strokes among the TAVR patients as well. The only Achilles heel, the only place where surgery continued to win, was in the realm of aortic regurgitation post-valve replacement. So the conclusion from this sub-analysis of Partner 2A and the SAPIEN 3 high-risk and intermediate risk registries was that TAVR with a SAPIEN 3 valve was superior with respect to mortality as well as stroke, whereas surgery remained superior from the standpoint of minimizing aortic regurgitation. Now, at the same time, looking back at the self-expanding platform, the same story plays out over here. This is the SIR-TAVI trial that Dr. Reardon, Dr. Kleinman from Methodist next door to us conducted. Intermediate surgical risk patients randomized to TAVR versus SAVR. And again, they saw very much the same story here. Looking at the endpoint of all-cause mortality or disabling stroke, powered as a non-inferiority trial, TAVR was again non-inferior to SAVR. And again, when you look from a sub-study standpoint, there were a number of indications that TAVR, from a mortality and a stroke standpoint, was actually better than surgical AVR. So that completes the second phase here. Among the intermediate risk population, intermediate surgical risk population, TAVR really has shown benefit both with the balloon expandable and the self-expanding platform. So the final frontier was to move into the low-risk population. Patients with severe AS at low risk for surgical AVR. STS scores of less than 4 in the Partner 3 trial, randomized 1-to-1 transfemoral TAVR versus surgery. The primary endpoint, all-cause mortality, all strokes, and rehospitalization at 1 year. Follow-up was at various intervals and ongoing through 10 years. So the interesting thing about this trial is we'll continue to follow these patients going forward to really understand durability. So we'll be able to answer that question in a decade or so as well. There were a series of registries here looking at some alternative access, but the primary arm of this trial was purely transfemoral TAVR versus surgical AVR. And here's the results. This knocked everyone's socks off. It wasn't just a win, it was a slam dunk. And keep in mind, this was a huge surprise to all of us who participated in this trial and have done this for nearly a decade now. This is surgery's wheelhouse. Surgery does really well with low-risk patients. It is a beautiful and elegant procedure to save these patients' lives. Yet, even here, TAVR outperforms surgery. Looking at each of the underlying endpoints here, and it wasn't driven primarily by the rehospitalization piece. I know it's easy to make the argument that, well, I'm sure they weren't dissimilar. It was just the fact that surgery is more invasive. Actually not. When you look at mortality, when you look at stroke, it was all better with TAVR versus surgical AVR. And yes, there was a substantial difference in the rates of rehospitalization.
I mean, death is less than 50%.
Correct. Correct. This is a substantially less invasive procedure that provides as good, if not better, a hemodynamic result with less morbidity and mortality. Same thing on the self-expanding side of the equation. The Evolute low-risk trial, 1-to-1 randomization, TAVR versus SAVR, and for the primary endpoint of mortality or disabling stroke at 2 years. Here's their Kaplan-Meier curve, again from New England Journal of Medicine. This was presented at ACC and published at the same time in NEJM. TAVR beats surgery among low-risk surgical patients. And looking at each of the endpoints here, this is all-cause mortality or disabling stroke. You can see statistically significant difference in favor of TAVR here. Looking at mortality alone, oops, went too fast there. Looking at mortality alone, again, TAVR beats SAVR. Looking at strokes, here there's a substantial difference. The stroke rate is substantially lower
I just wouldn't believe
with
it.
TAVR than with SAVR. And in terms of rehospitalization, yeah, it's a huge margin here simply because of the less invasive nature of the procedure. So
Well, it's still 50. I don't mean to interrupt you. Go back to that slide, do you mind? Yes, it is a huge, but it's 50%. Your mortality was greater than 50%. So yeah, the number may be different, 2.5 versus 1, and 6.4 versus 3.1 just sounds like bigger numbers, but actually the death benefit is a higher percentage than this percentage
correct.
by a small
the number
amount.
needed to treat to save a life is relatively low in these trials, which is amazing.
Yeah, yeah. Yeah, that's pretty impressive. I haven't seen this data yet. This is the first time I've seen it. I've heard about it.
Yeah, it's like I said, it knocked everyone's socks off. And the interesting thing about it was we saw 2 trials in the balloon expandable and the self-expanding realm that were very analogous to one another, and the results are almost identical. What that tells us is it's not a matter of what platform you're using. It's TAVR. TAVR works. It's safe, it's efficacious for any patient who potentially has severe aortic stenosis. Now that doesn't mean surgery's done. There are many indications where a patient needs surgery, bicuspids, those with ascending aneurysms, endocarditis. All of these other things still are very much the realm of surgery, and I hope surgery never goes away. It's a partnership. We work as a heart team. Dr. Nguyen and I, he's my surgical partner, Dr. Estrella as well. We work very, very closely and try to choose what is the right procedure for any given patient. So to repeat, this is the landscape that we've seen over the course of the last decade. We've marched down that surgical risk continuum. We now know that TAVR is safe and efficacious for patients at any level of surgical risk, and potentially better for the average patient with severe aortic stenosis. Thank you.
Wow.
Wow, very nice.
Okay, very good. That was excellent.
That's awesome.